Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders. I'm Chris the Chi-Man-Chu, and I'm here with our pediatric emergency medicine producer, Jess Kelly. Say hi.
Hey guys.
Tonight, we have two special guests. We have Dr. Julie Leonard and Dr. Dan Corwin to discuss pediatric cervical spinal injuries. But first, Jess, do you want to remind them about the show?
Yeah, we are the Pediatric Medicine Podcast. We interview leading experts in the field to bring the clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine. Tonight, we have a fantastic conversation with our two guests, Dr. Leonard and Dr. Corwin. Dr. Leonard is a board-certified pediatric emergency medicine physician who practices at Nationwide Children's Hospital. She serves as the Director of Clinical Research for the Center for Injury Research and Policy and is the Associate Director for the Center for Pediatric Trauma Research. Dan Corwin is also an attending physician and Associate Director of Research in the Division of Emergency Medicine and the Emergency Department Lead and Investigator of the Minds Matter Concussion Program at Children's Hospital of Philadelphia. Join us tonight to check out the new PECARN rule on who to image and how to use clinically sensible evaluations, learn that cervical spines can be cleared for very young children, and find out how to get the perfect odontoid view.
I cannot wait till our listeners hear this episode. My spine's tingling. That was all right. That was
pretty good.
Better than my last one. Hello, I have Dr. Leonard and Dr. Corwin here with us today. Thank you for coming on the show.
Thanks for having us.
Absolutely. Thank you for having us.
So because we're sort of an informal group, I'd like to first ask, can we call you by your first names?
Please.
All right. So we have Julie and Dan with us. So I'm going to start off with some quick rapid fire questions just so that we can get to know you and our audience can get to know who you are. So let's start with Julie. Can you give us sort of a couple lines to describe yourself and maybe something outside of medicine that you like?
Yeah, absolutely. I am a pediatric emergency medicine physician at Nationwide Children's Hospital, but the majority of my life is spent in the Center for Injury Research and Policy. And I affectionately call myself the C-spine girl because we're going to talk today about a body of work that has spanned my training and my faculty years, so excited about that. Fun fact, I have a cute little dog who's running around my feet right now named Lewis.
We should definitely have Lewis on the show. I feel like he's going to be on the show.
He's got personality. He's going to come up and join us in a hot second.
Excellent. Dan.
So I'm also a pediatric emergency medicine physician and also have a CERP attached to me. It's our Center of Injury Research and Prevention at Children's Hospital of Philadelphia, where I practice. And if Julie's the C-spine girl, I guess I'm the concussion boy. Of a lot of my research is around pediatric mild traumatic brain injury, but was lucky enough to be the site principal investigator for a large study we'll be talking about, led by Julie. Fun facts for me, and I can hear them right now. I actually have two dogs, two doodle mixes, both of whom just got very large bones that on the floor above me, they're having a fun time dropping and picking up. So I don't think anyone else can hear it, but I hear it's almost like a metronome of dog bones bouncing above me.
Oh, man. So we got two dog lover guests. That's fantastic. Jess, you got any questions?
Yeah, I love it. We have pen people here in the audience. I'm a budding pen physician, so I guess my favorite question to ask is, what would be the best advice you've ever received as a learner? And maybe Dan, we'll start with you for this one.
So I was lucky enough when I was in my training to get to work with Dr. Steve Ludwig, who's one of the founders of our specialty. And one of the first things I heard as a trainee was one of those middle of the night cases that we all kind of sigh a little bit of. It was an ear pain case, and it was not. And his advice to me was, how lucky are we that someone trusts us enough in the middle of the night to come in and have our child see us with ear pain. And to always think about why is a family coming in to see us in the middle of the night. No one wants to be in the emergency department. And I've tried to hold that dear. And I certainly still have those moments as I've gone through training and gone through faculty, but I try to hold that nugget in my head of how lucky are we that families trust us enough to come and see us.
Yeah, I love that perspective, especially when you're feeling like, overwhelmed or tired or, just reflecting back that like, this is really special and, these are the people they trust. So awesome. Julie, do you have anything you wanted to share?
Yeah, if I had to reflect on one thing that, I keep with me, it was really my program director from residency. And he was this gentleman that would use the Socratic method. So he'd sit there and he'd ask you question after question after question. And he could go on forever. He was like a true like Dr. House, and he would just go and go and go. And all he was waiting for you to do was say, I don't know, Dr. Keating. And, because he wanted you to have the courage to say, I don't know, let me go look that up, right? And so I try every time a new somebody's rotating on service, I try to encourage them. It's okay to not know. You just have to know how to get the facts, like where to go, how to do that quickly, So I keep that with me, have the courage to say you don't know.
I love it. Even I think with patients and families, sometimes, how do we don't always know. And so being able to say that is important.
Yeah. I mean, as the attending all the time, I try to model this also to my learners. And if they ask me a question, I'm more than happy to admit, I don't know that one. I'll have to look that up and I'll get back to you guys.
Hey, Cribsiders listeners, let's talk some more about Freed. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. So here's the backstory. Gabby, a family medicine physician, and Erez, a computer engineer, came up with Freed, a solution that could help alleviate the daily burden of overworked clinicians everywhere. And for Erez, selfishly, it could mean that he would spend more time with Gabby, who was spending nights, weekends, and holidays updating medical documentation. So what does Freed do? Freed turns clinicians' daily workflow into accurate documentation instantly. There's no training time, no onboarding, no extra mental burden. All the magic happens in just a few clicks, so clinicians can spend less energy on charting and more time on what they do best. Today, more than 4,000 clinicians and their spouses have fallen in love with Freed. So Freed is this AI scribe that makes charting go away, doing your soap notes for you. It is HIPAA compliant, takes 30 seconds to learn, and costs only $99 per month. But you can try Freed for free right now by going to freed.ai. That's freed.ai. And listeners of Cribsiders can use code CRIB50 for $50 off their first month.
All right, Jess, maybe we should just get into a case now.
Let's do it. Okay. So we're going to start with our first case. So a toddler is brought to the emergency department after being involved in a rollover motor vehicle collision. Their vital signs are normal and they're in a cervical collar. They are in no acute distress and on exam have no step-offs, deformities, or tenderness to palpation on their spine, and they're moving all of their extremities equally. So I guess kind of stepping back, we know this is an episode on cervical spine injuries, but are there any specific mechanisms that make you kind of more or less worried for a spinal cord injury?
Who's taking it, Dan?
Yeah, I'll let Julie start because there's going to be some interesting historical context here.
Yeah.
Not to age us, Julie, but of how our thinking has evolved over how much we focus on mechanism when we're thinking about immobilizing the spine or imaging the spine.
Yeah, and so that has spanned my career, right? The change in the way we think of trauma triage. So I still hold on to the first card I had that had the trauma triage criteria, and it was motor vehicle crashes of 20 miles per hour or greater, right? And that's
like every crash,
like every crash. To now where we there are certain mechanisms that should heighten your concern, but only prompting you to have a careful examination, not prompting you necessarily to order a medical test. And that's the difference where, at one time we'd actually used mechanisms and we would order testing based on mechanisms. Now we really use those to say, hey, this is a patient, I really need to pay attention to my examination and careful history with that patient. So things have changed. Dan, I think we probably do want to talk about a few of the mechanisms that you should be worried about for cervical spine injury. So I'll pass that one to Dan.
Yeah, and not to get to the lead too quickly, but when we get to the very large decision rule that we will talk about, one of, I think, the most interesting parts of it is that mechanism is not included in the decision to image or not image. But there are some, and when we look at the historical work that is looking at what is associated with a cervical spinal injury in children, the big one is always a diving mechanism. So this is not the toddler who is in the pool who might be found down, which is always a scary case, but this is the older child, the adolescent who dives into a pool that's shallower than they thought it might be. And I think that's the biggest. The other big ones are the really high speed, so not just 20 miles an hour motor vehicle collisions, but the truly high speed motor vehicle collisions. So someone ejected from the car, the rollover injuries, those are always a little bit more heightened. And then I mean, I'm missing there, Julie. Those are the big ones I think about are the high power cars.
I agree, and the CDC has done a nice job over time in defining that, right? And started to get away from speed and more towards signs, that there's been enough force to transmit to the patient that's in the car, right? So the intrusion into the passenger compartment, the ejection out of the car, so they weren't wearing appropriate, seat belt or car seats, death, as a marker. So if somebody else has died in that same motor vehicle crash in that same car, those tend to be more predictive than just speed alone.
So you were talking about the differences between like the toddler found down in the pool versus like the adolescent doing a diving injury. So obviously there's a difference in age there. Can you speak a little bit towards how age plays a factor in terms of risk, or is it not, or is it mostly because you have different mechanisms based on different ages?
So there are a few things, and I'll start and then I'll hand it off to Julie, but I think there are a few pieces. One is different mechanisms and also developmentally differences in what children can report. So particularly our pre-verbal children are going to give you different pieces of information that might allude to a cervical spinal injury compared to the older adolescent. But then physiologically, there's differences in our body type. So our younger children, relative to their body, have larger heads. And then their anatomic fulcrum is a little bit higher. So when we think about the same injury mechanism, so the same car accident that has a 15-year-old versus a 2-year-old might have different impacts depending on body type, depending on that difference in size of head relative to body. And then certainly when we think about restraints as well, of hopefully that toddler is restrained in a different way than the adolescent might be.
I think it also gets back, Chris, to what you did say, which is the activities that they're participating in. There are just vastly different between a 15-year-old and a 1-year-old. So, a 1-year-old is, mostly being supervised. And so when they have an injury event, it is an injury event that was unintentional and usually them out where they shouldn't be, right? Like, so falling out of a window, being hit by a car, unfortunately being in a motor vehicle crash with, their adult family members. But when you get to a teenager, they're independent. So they're drivers, right? And then they're playing sports. And, so sports becomes like a really important mechanism for cervical spine injury in the older kids. And that gets back to something that Dan alluded to. So diving as a mechanism, a true diving accident where you dive into a shallow pool. But also if you think about sports and other ways that, a kid that dives in and hits their head on the frame of the soccer goal, right? and an axial lobe, injury. So it's not classic diving, but you have that same sort of impact. So it is a little bit that, depending on age, also, different activities.
Are there any other comorbidities or other populations at risk? So I recently been looking at some scripts where we're probably going to have a Down syndrome episode coming up. Are patients with Down syndrome, I assume these are ones that we'd be extra careful on when you're doing your assessments. Are there any other types of patient populations, patients with other comorbid issues you might be considering looking at?
That is another way that, it's sort of exciting that the new decision rule that we'll talk about in a bit, in that we used to be really concerned about certain subpopulations like children with Down syndrome, individuals that have any sort of disorder that affects their bone, muscle, or ligaments, or other syndromes that result in abnormal development of the cervical spine. And we had at one juncture in the history of developing this decision rule sort of deemed those patients as always needed to be screened. And what we have found and what we'll talk about is, yes, again, just like if you have a serious mechanism of injury, you should be very attentive and perform a very good physical exam and should have a medical exam, right? It should be a reason to get a medical exam. But it isn't an indication in and of itself that you have to get x-rays on every child that has Down syndrome. But you should have a heightened level of awareness. If they have an injury event, they should go and see a physician and they should get examined. I think that's the biggest take-home message, yeah.
Yeah, and the other things you'll hear about achondroplasia, osteogenesis imperfecta as things that might predispose, but I think we're going to say this a lot of the physical exam is really critical, and imaging does not replace a physical exam. And a lot of what we'll talk about is almost de-implementation of, we want to minimize radiation, whether it's from X-ray or from cross-sectional imaging in our youngest patients who can have long-term effects from that radiation.
And to build off on that, can you talk a little bit about the physical exam? So I assume like you're looking for any point tenderness, you're trying to make sure they can move all their extremities, things like that. What are you looking for on your exam?
Yes, so the nice part again, and we'll probably have that, ta-da, here it is, but the nice part is it's just a really good trauma evaluation, right? A head-to-toe trauma evaluation. That is what these patients need. We need to make sure that we inquire from the patient where they hurt, right? And then, what their complaints are, and then, top to bottom, the ABCs, D and E, it's just, it's really just a careful exam. I would say that in general, the components of the exam that are most important for predicting cervical spine injury are mental status examination, your airway, breathing, and circulation, and any examination of basically your central body, so head, neck, and chest and abdomen.
I think we should keep hyping the rule without talking about it, because then the ta-da moment is going to be phenomenal. But these pieces are going to fall into it. And the other thing I would say to any trainees who are out there listening is, do it the same systematic way every time. So it's easy to get distracted by if someone's complaint is neck pain, going right to the neck if you have a deformity in an extremity, short of one that is life-threatening from a circulation standpoint, for example. But in the same way every time, so head to toe, and your primary survey and your secondary survey. And if you do them the same systematic way every time, you're less likely to miss or forget something.
We talk a lot about cooking on the show, and for good reason. There's nothing more important to any medical professional than eating. Cribsiders listeners, today we're going to talk about Caraway cookware. Caraway cookware is beautiful ceramic cookware that's easy to use and looks fabulous in your kitchen. Honestly, I leave my cookware right on the stove just as an art piece. I love the ceramic's natural slick surface. All you need is minimal oil or butter and everything just slides right off the pan. Better yet, cleanup is super quick, and that's a must-have in our family. Not to mention that Caraway products are made without any toxic materials like PFAS, PTFE, PFOA, or any other very hard to pronounce chemicals. This cookware is loved by over 65,000 people, including us here at the Cribsiders. So, listeners, it's time to try it for yourself by going to carawayhome.com/Cribsiders to see all of our favorite products and the cookware we use to make cooking easy for even the most amateur home chefs. Plus, take an additional 10% off your next purchase. So this deal is exclusive for our listeners, so visit carawayhome.com/Cribsiders or use code Cribsiders at checkout. Caraway, non-toxic cookware made modern.
You're going to have to remind me of some things. It's been a while since I went through my training and then also done any like ED or trauma shifts. Can you explain what these surveys are, or at least like At least in the broad strokes, and then maybe some of the more neurological stuff. Like, are you palpating along the spine, or these other things? Are you taking? I know we'll talk about the collar in a second, but are you like making them do all sorts of range of motion? Like, what does that include?
Yeah, and I'll do the ABCs and then hand it over to Julie for the more in-depth D, which is disability, and we get into the neurologic exam. But we always start with our ABC. The A is airway. So is the airway patent, is the older patient talking, is the younger toddler crying. B are breath sounds, so do we have equal and bilateral breath sounds? And along the way as we go, if we find something that's abnormal, so the patient who isn't spontaneously talking, if you don't hear air entry on one side, we're going to stop and intervene. And the C is circulation. Do we have strong peripheral pulses? Do we have a normal heart rate and a normal blood pressure? And all of those are actually quite relevant for cervical spinal injury. If you have an injury that's severe enough to compromise those, and when we get to the role and have our big ta-da moment, one of the highest risk factors is something abnormal in that primary survey. And it's because if you have a mechanism that's severe enough to cause an alteration to your airway or breathing or circulation, you're just at higher risk for that also to impact the cervical spine. And then we get on to D in our neurologic exam.
So, the D portion of things is any weakness, any sensory changes, including paresthesias, should heighten your level of suspicion, for a cervical spine injury. Again, mentation is an important component for several reasons. We've alluded to the head first impact. So not only could mental status be reflecting a patient who has had some downtime and, some injury from poor airway breathing and circulation, but that head first axial load impact, that is going to, result in a brain injury. And so there's a lot of comorbidity between brain injuries and spine injuries because of that, head first impact that, of course, causes both. So that group and that first primary survey is really where you can pick up on the set of children that are likely at the highest risk by just merely, that first pass part of your survey. I would say the next step is, in the process would be moving on and, the full examination, the head to toe examination of the patient. And the neck exam is incredibly important. And there, however, is sort of a situation that changes over time, and that gets into the self-report of neck pain and does your neck pain hurt. Interestingly, in young children, we're so afraid that they can't tell us where they hurt, but they actually happen to be the most reliable reporters of where they're injured. So lots of work in other injury patterns have shown that, like, if a child has a small buccal fracture of their forearm and you say, where does it hurt? Just show me one spot. They'll just point right at it. And, so they're pretty good reporters. So, and it's pretty uncommon also for a child to report neck pain. Me, on the other hand, I sleep wrong and I'm reporting neck pain. Little child, not so much. And so it's important as part of that neck exam is first not touching anything and asking, does your neck hurt? And then, of course, it's important to take the collar off then and to fully inspect the neck. And most importantly is the posterior neck and along the midline, the spinous processes and palpating to see if there's any tenderness there. And then finally turning the neck. So Dan earlier commented, sort of the fulcrum of motion. So what do we mean by that? Where you turn your neck. So believe it or not, most adults, most of their head turning is in their lower spine. But in children, the head turning is, the lower part of the cervical spine. Most of the head turning in a young child's actually up high in their C1, C2 area of their spine, and that's where they get the majority of their motion. So if they have an injury, not only is it more likely to be there, but you'll really see it with head turning and their ability to move their neck. And so that is a very important component of this examination.
Do you feel comfortable letting patients turn their neck, or are you worried that you could further exacerbate a potential cervical spine injury?
Me personally? No. but what I would say, and Dan, you can weigh in on this because you may have, a different practice style. I certainly, if I have somebody who has altered mental status, who has any signs of any neurologic findings, I'm not going to ask them to move their neck around, right? But if I get through that portion of the exam and I don't see anything, I'm going to be really comfortable. If they don't report pain, they don't have tenderness, I have no problem asking them to move their neck around. And, that pretty much, and once they do that and they still say no pain, no tenderness, I think their neck is
clinically cleared.
Yep, clinically cleared.
Yeah.
I don't know.
Yeah. So I was going to say that it's not the first thing I'd ask them to do, but once you've gotten through, first, does it hurt? And second, as I'm palpating, does it hurt? Then absolutely. And I think we're going to talk about collars and their role, but especially, we get, once they're in the emergency department, really scared about any minimal movement and is this exacerbating something. But think about like the toddlers come in and is screaming their head off and flopping their neck all around, and the amount of strain they've already put on it before they walk in. If they're doing that and they're still having, a lot of reassuring physical exam findings, the likelihood that there's something underneath there and we need to then try to completely immobilize that terrified 2-year-old, it's a different ballgame there.
And maybe to build on that, the patient in our case came in with a cervical collar in place. Could you guys talk a little bit about like who ends up placing a cervical collar, why do they place it, and things like that?
Yeah, so traditionally, that stems back to sort of early EMS days where the guidance was everybody had every injury until proven otherwise. And it was actually codified that way in ATLS. They basically said, assume every patient has every injury until you get x-rays. And it was the standard of care without, even batting an eye. And so what ends up happening then is, patients will come in, the collar's in place, and some of our earlier work actually demonstrated having the collar in place really does affect how we think about the patient. We were already sort of in our minds, they're cast as being more injured than maybe they are, right? Somebody before me thinks they need a collar, so what am I missing here, right? So there's already, we've got this different perspective on the patient. And we demonstrated that also that physicians often won't do exactly what you asked me. They won't take off the collar and they won't examine the neck. And so, again, that hesitancy to actually perform the full exam. And then finally, I don't know if you've ever had a collar on, but it does not feel good. So not only that, then kids are coming in and they're complaining of pain and having that collar on. And interestingly, we have really allowed it to be a really liberal practice. So we also allow our nurses to just, grab collars and put them on, right? And we don't spend a lot of time training our nurses about clinical prediction rules. So they, whatever context that they were trained in, that's going to carry into their nursing practice. So if they were someplace where every patient that walked in the door that was in a motor vehicle crash automatically got a collar, they get a collar. So I think when it comes to physicians, we usually, physicians make a decision if they're going to clinically clear or not before they put that, collar on. And so ideally, I hope we get to a point where we use a rule at every juncture before we ever put the collar on.
One of the really neat things about the study that we'll talk about that really is Julie's vision is that it didn't start when the child arrives in the emergency department. It really starts from EMS's involvement. And it's one of the first large prediction models like this that not only includes the perspective of us in the emergency department as clinicians, but the EMS provider. And to what Julie's alluding to, it's hard to be an EMS provider. We in the emergency department, we have so many resources. We're not transporting anyone anywhere usually. They're right in front of us. We're not going large distances. And we already have a really narrowed down framing. And as pediatric emergency medicine experts, we don't have to think about people generally above the age of 18 or 19 years old. That is the EMS training, is to be err on the conservative side and trying to figure out places where we maybe don't need to be as conservative as we traditionally have, because as also Julie alluded to, no intervention is benign, and even putting that collar on, but from the framing bias that then it leads us to do more, But also she's done great work showing that it increases pain scores. Kids are uncomfortable. So even something that seems as simple as we're just putting a collar on, it's not that big a deal, can have a lot of downstream effects.
Hey, Cribsiders listeners. Easy Resus is your ultimate support to take care of your sickest patients during resuscitation. Whether you are taking care of a newborn during a precipitous delivery, a septic child needing endotracheal intubation, or seizing teenager, this offline app has drug dosing, equipment size calculation, treatment algorithms, all available in under 3 clicks. This gives you rapid access to life-saving critical info in a user-friendly interface, taking care of the logistics of resuscitation so you can take care of what really matters most. That's your patient. So for those who do not work with critically ill patients, that's okay. The app also has calculated doses of the most used PO medications, including antibiotics and analgesia. Although you can find critical first steps for basic and advanced life support, which could be useful for anyone anywhere. Finally, for those who also work with adults, there is a complete adult section with the same features as in pediatrics. So Easy Resus has drug dosing, the treatment algorithms, and equipment size dynamically calculated based on certain patient characteristics. It also has multiple alerts and content adjusted to age and weight to ensure safety. So someday you'll need to act outside your comfort zone, and with Easy Resus, you'll be absolutely ready. And for Cribsiders listeners, Easy Resus is offering you a deal. Listeners of the podcast get access to 2-month free trial with access to 100% of the app features. So here's how you do it. You download the Easy Resus app. That's spelled EZRESUS on the App Store or Google Play Store. Create your account, then use the promo code Cribsiders. That's code Cribsiders on the Easy Resus app. And for more information, you can visit easyresus.com/Cribsiders.
So I think we're getting down to like probably the biggest question of the episode. I don't have a lot of experience here. I just remember my times when I was a resident, and I think mostly with the adult patients. I just remember there are all sorts of rules when we're trying to decide on imaging. Like I know out of Ottawa, they always have Canadian rules of some sort of things. I remember a nexus of something else, but I don't even know how well these are ever even applied to pediatrics. So I guess the big question is like, can you help us at least start the discussion on how we're looking at imaging, at least in the broad strokes? Why are we getting imaging for these patients?
I'm going to start and then I'll turn it over to Julie because this is her career, is this work, and it's led up to this. And I can also, if I'm concussion boy, I can be her hype man too, because this is an incredible study that she just completed and led across 18 pediatric emergency departments to do exactly that, to derive a rule that is specific for children. So the 2 big NEC rules, the Nexus rule and then the Canadian C-spine rules, either had very few children or 0 children. So up until 2 months ago when we published, I think 2 months ago, there was not a large pediatric specific rule that could be applied to say, here is where you get imaging for children and here's where you do not. We try to extrapolate those rules. There had been some studies done by Julie that had some associations and some early rules, but there had yet to be the large definitive predictive model of here is the person who's at such low risk that you do not need to get imaging. You can clear them clinically with your good physical exam and send them on their way from a next standpoint.
And I think another aspect of how this decision rule differs from Nexus and the Canadian C-spine rule is those rules were about imaging or not. They didn't give any guidance to what type of imaging. They didn't take into consideration like pretest probability. Like, we have multiple choices when it comes to screening for an injury with an imaging study. So we can get plain x-rays and we can get CT. The adult rules, they just say this patient needs to be imaged, yes or no, without guidance. And what we really want to do is we really want to reduce the CT scans, right? The ones that have the greatest radiation burden. So the great part about, being able to start fresh and design your own rule is the ability to do that, to think of things, in a way that is useful to the clinician.
So I think we should dive in, and actually, I think we get to have the big unveil here in the ta-da. So
let's do it.
And I'll let you should take this away, Julie. I mean, this has been decades in the making of how we've stratified and how this rule has come to be.
Yeah. So I think, again, we wanted a rule, and we're pretty deliberate in the design process. So this wasn't a design process where we just threw a bunch of variables in and said, let the machine spit it out and tell us what to do. So we were pretty deliberate in how we approached it. So the first thing was that we really wanted clinically sensible variables that, really are not open to a lot of variation in interpretation. So as an example, nothing like a painful distracting injury. It's either you have a regional injury in some part of your body, you have a physical exam finding that's very specific, but not, something that is really could be open to interpretation. So we first really thought about clinically sensible variables, and we had studied those over time. So that's the first thing I would say about model building, right? We're very careful about the types of variables that we studied and observed. I think the next thing is that we actually built the decision rule in two parts. And so, as Dan and I have been alluded to, we wanted it to correspond to two things: the natural flow of your clinical care and your physical examination. And again, that idea that we need to find that population we can triage to CT, right? So there are some, can't miss situations and groups of patients that really do need to be imaged, and we need to know who those patients are. And so we took and first defined a group of variables that if a child had one of those, it was greater than 1 in 10 chance that they had a cervical spine injury. So really heightened risk, right? It took our pre-test probability of 1% and then bounced it up to, 10% or greater. And the set of variables maps directly to what we talked about, your primary survey, your sort of ABCs, and sort of that stop and do something moment. So do you have abnormal airway breathing and circulation? Do you have altered mental status where you're going to intubate the patient? Their GCS of 3 to 8. Do you have a focal neurologic examination? And for the pre-hospital providers, GCS calculations can be hard. So also in that grouping, it's the AVPU of a patient who's unconscious, basically, AVPU. So U on the AVPU scale, the patient's unconscious. So if you have one of those 4 variables, again, those patients are at 1 in 10 had a cervical spine injury. And that's where sort of the cost benefit of getting a CT, it pays off. And so that group, we then removed them from modeling. So if you had one of those variables, we removed it from modeling, and then we conducted a card analysis. So go ahead, Jess. Yeah.
I was just going to ask, abnormal airway breathing or circulation, I guess I just so specifically want to know, because you could say someone, their circulation's abnormal because they're hypotensive or they're slightly tachycardic. Where did you specifically draw the line in terms of abnormal ABCs?
Yeah, so we let the clinician draw the line. So it was a clinician observation. All right, do you have an abnormality on your airway breathing and circulation that is going to cause you to intervene? And then and that was it. And so that allowed, again, being clinician driven, right? Not getting into, we have to calculate a heart rate and age adjusted parameters. No, this is you're looking at the patient and you're like, holy cow, they have multi-system trauma, right? They've had enough force that we're gonna have to screen them for injuries, and so that is that patient. I think most of us feel as clinicians pretty confident about. We're like, time out, this is patient's sick. I'm going to pass the second tier off to Dan. I'm going to let him talk about the second tier of findings. So the prediction rule says you have any of those 4 findings, CT scan. Then you move on and you assess patient for sort of the next tier of findings.
Yeah, and CARD is a classification and regression tree analysis, and it's just another way of statistical modeling. And rather than every factor going in together, you're doing one factor at a time and pulling one factor out. It's just a way to group things into 2 buckets. So at each point, do you have or not have the presence of this feature? Do you have cervical spine injury? Don't you? Start with the one that has the highest likelihood it gets pulled out, and you go down and down and down. So we have those 4 high risk factors. So the GCS 8 or below, unresponsive, the abnormal airway breathing circulation, or a focal neurologic deficit, that's the 12% risk you get pulled out. We're recommending the CT. And then we have 5 additional risk factors. So altered mental status. So that's a GCS in that 8 to 14 range. So you're not obtunded, but you're not acting totally normally. So that's 1, altered mental status. Then we get to the neck. We're going to go all the way down, head to toe. So if you're reporting neck pain, or you have tenderness when you're palpating, so those are 2 and 3. And then if you have substantial head or torso injury. So as you're going through, you've identified, because you have done other testing, you have clear signs that there is very substantial injury to either the head or torso. So if you have any of those 5, after we've pulled out the group that's high risk, you have about a 3% risk of a cervical spinal injury. So that's way lower, but it's still above the baseline risk of 1%. And that's the group where we think about, can we potentially spare them the ionizing radiation of a CAT scan? And that's where we're recommending an X-ray. Yeah, go ahead. I'm sorry.
Yeah, so I guess I can sort of see how you guys were saying that it works well with the flow, because with those high risk factors, those are things they're walking in, you sort of already know a history, they already have their, your first primary survey is really quick, and so you can quickly get those to CT, and now you're like, now I'm at the altered mental status is not, their GCS is a little higher, and I'm doing my physical exam and saying, where are we going from there? Am I getting that correct?
Absolutely.
Yeah, and
I would say,
I was going to say some of those, and I want to be really clear. The substantial injuries are injuries that you need to intervene for. So these are injuries that they're going to go to surgery for, or they're going to get admitted to the hospital. So like a simple linear non-depressed skull fracture, that wouldn't be our substantial head injury, right? We're talking about a basilar skull fracture. We're talking about they have, their gourd is open, right? Like, it's like not like, this is, it's really meant to be things that are signs of significant biomechanical force on the body, such that there's a higher probability of having multi-system trauma. That is the type of injury you're looking for. So, do they have a flail chest? Are they, do they have a rapidly expanding abdomen where you're like, oh, we're going up to the OR. Those patients, you don't even need to wait for the test, because you look at them and okay, well, when they go past the radiology to get, their abdominal study, I'm going to get x-rays of their spine before they go up to the OR.
Do you think there might be some cases where you maybe get a CT abdomen and pelvis because you see a seatbelt sign or whatever, and then find out, oh yeah, there is this high grade, splenic lac, and now this is a kid who might go back for cervical spine plane films?
One, with the nice thing is, now with our trio of decision rules, ideally you're going to pick up on sort of those high risk findings before they actually hit radiology. I would say that, the injury truly was occult and you couldn't call it in the trauma bay. You probably need to go back and examine again and think, okay, what, because there might be something that's isolated, a handlebar, to the abdomen, where something's really focal, and you can clarify that with history. But if it was a motor vehicle crash and you have an abdominal injury, you need to think twice.
From the get-go.
Yeah.
So with those high risk factors, we're looking at CT. For some of those lower risk factors, if you find them, we're looking at plain X-ray. What type of X-rays are we looking at? Is it just a cervical, like plain film? Are we doing like flexion extension on them? Like, or is that like, we're worried, so we won't do flexion extension on them? Like, what are we looking at now?
Yeah, and I don't know, we could do a whole other podcast on the cervical spinal thing itself, but I think the key is multiple views. So the single view, and sometimes we'll do this when we're in the resuscitation bay and we have a really sick patient. We get a single lateral view because that's all we can get in the moment. And that's different than the patient who comes in who has a normal GCS and normal ABCs and no focal neurologic deficits and has that pain. So you have a little bit more time. And then you're trying to get multiple is at least 2 and really 3 views. So there's the anterior posterior view, there's a lateral view, and then there's the odontoid view, where you're starting to put a little bit of stress on the cervical spine itself to get a little bit more of a dynamic study. And that's before getting into the flexion extension x-rays, which are also looked at in this study.
So definitely if you have a lateral and AP view of the cervical spine, 90% of injuries will appear on those 2 views. And the ones that don't appear, usually it's in that class of patients that we talked about, the highest risk patients. And the reason is that there's these overlying tubes and lines, and you actually miss the injury because of other difficulty positioning the patient, or the patient has tubes and lines in place, and you don't actually see the injury. But again, that's the group that you're going to triage to CT. A caveat I was asked about recently that I do think is probably worth mentioning. And in our PECARN head injury rule, if you are in the ED and your GCS is less than 15, the recommendation is a CT scan. And if you have a child that gets a head CT scan, it used to be this concept of, okay, well, also get a limited C-spine, so that, that open mouth view that's hard to get in kids, you can get it on that sort of limited study of the cervical spine. But the truth of the matter is you can actually see that on a head CT. And so what you need to always ask your radiologist, if you have a patient that you're screening with plain films but you can't get a good open mouth, is how did it look on that head CT that we got? Because it's there and you see the cranial-cervical junction well. You don't need to actually order a separate test to be able
That's
to do that.
That's a great pearl that I did not know.
Yeah.
I think we had talked about this, Julie, when the study was starting, but our classic was, when you're getting the head CT, just go down to C1, C2. It's not any more radiation, right? But when you talk to the radiologist, it's a little bit of a different story, right, Julie?
It is. So people have this mistaken belief that like you get a whole body scan is like you get it all in one pass, and that's actually not the case. You reset up and you reprotocolize. So the adjacent areas are actually getting passed over twice. So there is no such thing as like, extend it down. It's actually on a different plane altogether. So in a different positioning and setup. And again, it's just one of those misconceptions that people have about CT scanning.
Can I clarify that? Because I feel like people, I guess I hold this misconception that it's less radiation to do like a CT head and CT neck all in one than to like get the CT head and then go back. So it's literally the same.
It's the same.
Wow, that makes me feel so much better.
And that's where your question about, do you go back up and get additional imaging of the get it all together is much more of you have an unstable patient who you want to get these answers now than it is you're saving anything besides the transporting time. And for, again, the patient who's a little bit more stable, who are in this middle part of the rule, you probably do have a little bit more time to have a thoughtful physical exam. And then if you've gotten an x-ray, to do reassessments, because some of these things are dynamic, which is a really important part also of, there are some fixed things in decision rules. There are some dynamic things. A lot of what's in here, there are dynamic parts of it.
Yeah.
Go, Julie.
Yeah. Well, it's the comment about it. You're constantly reevaluating the patient. I think it's a great comment, and an important comment about like injured patients is always that sort of reassessment. One of my, again, favorite tricks is, particularly because kids complain about the collar, I will go in and I'll say, you'll ask them if their neck hurts, and they'll complain that their neck hurts because the collar hurts. And I'll say, well, if your neck hurts, then I can't take the collar off. So does your neck really hurt, or is it the collar? You have to, it isn't not a comfortable device, and oftentimes they're not applied appropriately. So they're not even wearing it appropriately. So it's, sometimes you have to play a little bit with kids to get them to give you the information that you're seeking from them. if a kid really has neck pain, they will let you know. They'll answer that question the correct way, which is, no, my neck really hurts, so.
I really appreciate you guys going through the work you guys did with PECARN. Are there other things that you learned from the trial, other pearls or other nuances that you want our listeners to know about? Or other even lessons learned that you guys discovered? It's like, oh, I didn't even think about that.
You get to go first, Dan.
I guess go first.
I'm trying not to monopolize.
No, it's okay. I'm sure you have plenty of them. So I just want to, before we move on from the first rule, just throw out some numbers just to give you a sense of scope of both the rule itself and the reassurance if you're not meeting any of these 9 risk factors. So I don't know that we've mentioned yet the number of patients enrolled. Over 20,000 patients, 22,000 patients were enrolled in this to derive and validate this rule between 0 years old and their 18th birthday. And then as we're going step by step, about 1,500 were in that high risk group. And those are the ones with the 12% risk of an injury. Another about 7,500 in the middle risk group, that's that 3%. 13,000 of the 22,000 had none of the 9 risk factors present. So the most likely scenario here is that you do not have a risk factor present. Of those 13,000, 29, that's 0.2%, had a cervical spinal injury. And it turns out of those 29, when chart reviews were done, 20 of the 29 actually had one of the risk factors present. It just wasn't filled out on the form. So there were 9 of 22,000 kids enrolled in the trial who had no risk factors present, who had an injury. None of them needed any surgical intervention. So nothing is black and white and perfect in medicine. This is a pretty darn good rule in terms of feeling good that if you don't have one of these risk factors met, you don't need to get any imaging at all, and you can allow your patient to either evaluate their other injuries or allow them to go home. In terms of interesting, surprising things, to Julie's point about our goal is really minimizing that CT and the ionizing radiation from CAT scan. Overall, when we looked at imaging rates, about 17% of the patients in the study got a CT. These are pediatric emergency departments where we tend to be very stewardly about how we use ionizing radiation. So almost 1 in 5 kids who show up with blunt trauma are getting CT. If the rule was applied, that rate would have dropped down to 7%. So we're getting rid of 2/3 of the CTs and saying we might be able to get by without ionizing radiation. That number is just, I think, so illuminating and just so impressive when you look at just the scale of what we're able to do from just our pediatric emergency departments, again, where we have a much closer eye on do we obtain CTs or not. Some of our general emergency departments, because they have to, from their volume of trauma and their breadth of patients they see, have to be a little bit more protocolized or getting imaging at a much higher rate. So huge potential for making a positive impact in terms of minimizing ionizing radiation. I'm sure Julie has a lot of other lessons learned, having spent a lot more time digging into this.
No, I think that is one of the key things. There will be a lot. You have a database built of 22,000. There's going to be a lot of evidence that's going to flow from this, and so keep your eyes out, for that. Dan alluded to the practice variation. So we saw practice variation. A lot of it was accounted for by whether or not patients were first seen at a general emergency department or presented directly to the pediatric emergency department. So a lot of that imaging was actually happening out in our community emergency departments where they were getting CT scans and then were transferred in. And important about that and the way that we can have the biggest impact is that most children are actually cared for in those settings. So we think, children's hospitals, everybody goes to them. Majority of people must be seen there for their injuries, majority of children. But in fact, it's 70 to 80% of the kids are actually seen in community emergency departments for their injuries. And so the most important thing for us is to do exactly what we're doing here, right? Is to disseminate this information very broadly out into the hands of all the people that are caring for children after trauma events and screening them for injuries, because that will have much more impact than anything that we'll be able to do, in our children's hospitals. And then I think the other thing to keep an eye on is, Dan mentioned that we had gathered information from other providers to sort of demonstrate, can this rule be actually applied by other providers? Can it be applied by EMS providers? what do our surgical colleagues think? Will they make the same observations? If we're standing side by side, are we going to start arguing over, what to do about this patient? And what you will see as the literature comes forth is that we were able to show really good agreement between clinicians on these findings and the ability to apply this rule very broadly.
It's amazing. I think like just knowing that you have a clinical decision rule that you can rely on just makes providers feel so much more comfortable. I know with like the PECARN head imaging, it just makes me feel good about sending a kid home. And so hopefully providers are going to feel really good about not getting the imaging. Thanks to you guys.
Well, and I think the fun part is we're going to get to find out. So as part of this, and then the next round of studies is exactly what Julie was alluding to around implementation. So one of my big lessons of career lessons from getting to work in our fabulous injury center here at CHOP is that publishing the research is not the end result. It's step one. So exactly like Julie was alluding to, you don't lead to practice change just by writing a manuscript. There's so much more that needs to happen. And, in the last decade or so, this wonderful field of implementation science has been not just developed, but disseminated, has been implemented, to turn a phrase. And now having that as a tool to evaluate how do we get people to adopt this, what works, what doesn't, how do we understand the workflows of providers at various institutions who have various resources, who have very varied training, so that they all have access to this rule and are implementing it in a somewhat standardized way. And that's going to be the next frontier of this. Is the rule is out there and it's wonderful, but it's not the end.
Yeah. One of, and Dan and I have some additional work that we completed together for this project, which was getting out and interviewing providers in different practice locations. And one of my favorite interviews was in a small rural hospital in Utah, and just talking to the provider, and it was really very validating, because his comment was, these are my neighbors, right? Like the people are coming in, I know them. And, people make the assumption that I want to, that I wouldn't use a decision rule. I'll just want to CT everybody. But no, I have to actually pass that charge on to them. Healthcare is expensive. If I do any of these things, my neighbor, it's causing, harm to my neighbor. I would much rather have a decision rule where I can make a choice. I can keep them in my community. I don't have to do unnecessary testing. And so that's the audience we want to get to, is, those people who are out there and are, providing medical care to their communities, and, sort of empower them to make decisions about kids.
I know this is a little bit outside the scope of your study, but we talked about, who to CT, who to get the x-rays on, but what do you do? Could you talk a little bit about the patient in front of you where you get the imaging and it's normal, but they still have some midline tenderness? What's your next step, or how do you manage that?
That's another on the horizon, study. So, and it's one of those things that you have to decide where your funded study starts and stops, right? And so there's a lot of work going on right now to decide, do we really need, if they have just neck pain and the plain films are normal, do we really need to keep that collar on? And do they really have to come back and see a specialist to be cleared? And a lot of emerging evidence is suggesting that, they could either self-DC the collar at home and they don't need to come back if their symptoms resolve, or perhaps they don't need it at all. And so that's an active area of inquiry right now. Dan, do you have additional thoughts about that?
Yeah. I don't think we have the evidence base to say this is exactly what you do. So I think you're going to find a lot of practice variation, Jess, and having just finished your fellowship, you experience a lot of practice variation, whether it's the pediatric emergency medicine attending physician you're working with or the trauma surgeon you're consulting. You're going to get various answers. I think one of the keys that maybe we forget about is that reassessment piece. So these risk factors are dynamic. The person who has a GCS of 14, if you give them a couple hours, they got the x-ray, it was normal, now their GCS is 15. It's a different ballgame. They had the neck pain. You gave them ibuprofen. The neck pain is gone. That kid, you can feel pretty good about saying, we're done, we can send you home. I think it's that child who has the persisting isolated neck pain and no other findings. So they don't have any neurologic findings. They don't have any substantial head or torso injuries. That's the one thing they have. And to Julie's point, I think maybe we are overutilizing sending them home in the soft collar that who knows what that's actually doing, or if someone's wearing it, do they need to follow up and utilize the resource of a trauma surgeon? And hopefully we get some data that can let us feel more comfortable with what a fair number of providers are doing already, which is saying you have a little bit of persisting neck pain, but you have a little bit of persisting neck pain. We're not going to go much further than that because you've seen this, Jess, where there are those kids who are admitted to the hospital to get an MRI the next day.
All the time.
A lot of the time when they wake up in the morning, they don't have pain and then they just go home.
I love it. And can you maybe for our listeners explain, like, what is this whole soft collar, hard collar?
Oh, yeah. Do you want to talk about soft collars, Julie?
Really, they are strictly for patient comfort and not really for treatment. And I think that's something that people need to keep in mind. If a patient, if you really have a degree of suspicion or sort of residual concern, they should be placed in a hard conforming collar. And so I think that that's sort of the critical piece of things. So it's, if, somebody has a neck strain and you're just trying to help them have the reminder to limit their motion a little bit. And, that a soft collar is fine, but it isn't, really going to protect a patient that truly has an injury.
Awesome. Well, Dan and Julie, thank you so much for coming on tonight. I feel like we have learned so much from you both. I guess I'd like to ask if you guys have some main take-home points that you want our listeners to walk away from after listening to this episode.
I'm going to let Dan field it first.
So I think check out the rule. We're really excited to have it be implemented, and keep in mind that it is a guide for who to image, who not to image. It's not perfect. You still get to use your clinical judgment. We don't want to supersede that.
And I would say that, yes, check out the rule. I think you'll find it's clinically sensible, that it can fit into sort of your standard approach to evaluating a patient. And final sort of pearl or piece on this one is that you can clear the cervical spine of a very young child. So, the study included children that down to birth, and we had half of our study population was under 8. We had 54 children that were in the 0 and 1 year age category, and you can clear them. It's, it is not, they're not a little black box that, that you can't, examine and figure out what's going on inside of them. The rule works for them too. So
can you actually talk a little bit about that? We would love to hear, like, how do you clear the cervical spine clinically of an infant?
Exactly the same way. So if you think about what it takes to injure, the cervical spine of a young child, it takes a lot of force. And so those kids, it's not subtle. They are going to be the ones that come in and they are going to have comorbid head injuries. They are going to have multi-system trauma. They're going to be victims of non-accidental trauma. It's not a subtle group. So you would examine them exactly, the same way and same approach. In terms of very interestingly, and again, stay tuned. One of the strongest predictors in that early toddler was self-reportive neck pain. So they are able to tell you their little necks hurt once they can give you an indication of such. So. But the biggest predictors were mental status and focal neurological deficits.
If you have a toddler whose only cause of distress is the fact that you're having them wear a cervical collar, you can take off the cervical collar. I think that's the big thing, because it's Not fun for anyone, but particularly the 2-year-old who's in a strange environment who doesn't understand what's going on. They are trying to run around the room, but they can't because you've restricted their motion.
Yeah. And, one of my my favorite pediatric neurologists, we called it Dodge rounds. I loved going with him to watch this neurologic exam in small children, because all you have to do is play with them, right? Like a little child squats down, stands up, it gives you high fives, it's done. Like you just have to watch them move, and they are showing you the entire exam. And people say, well, what does a child do that has lost sensation, right? Like, what do they do? What if they're having paresthesias? You'll see them actually cover the limb that's numb, and you'll see them sort of protect the numb portions of their body, or shake their hands if they have paresthesia, so that they actually show the findings.
That's so interesting. I don't think I have seen that yet in my career, but I'll be on the lookout for it. Awesome. So I guess our last question for you guys, is there anything that you'd like to plug, any resources or things you'd like to refer our listeners to, or things they should check out? And it's okay if you don't.
Things that they should check out. I would say that we are working actively to create tools that you can keep in your pocket, put on your phone, really have at your hand until you've got this rule memorized, like the PECARN head injury rule. So there's a nice little visual aid to help people that's available online through the EMSC EIIC. We are working with the major, like UpToDate, MD Calc, Epic, all of the individuals that provide decision support that we frequently rely on in the moment, to make sure that we have a visual aid or calculator, that people can really use at the bedside to sort of keep remembering it until they've got it ingrained.
Awesome. Well, we'll be sure to include that for our listeners. Go ahead, Dan.
I was saying there's a wonderful Twitter account for PECARN that you can also find the visual aid there. And as these follow-up studies come out, because there are a bunch of planned secondary analyses, that's a great way to keep up to date on them as they're published. That's one of the ways that you can know that they're out there.
Awesome. Thank you both so much.
Yeah, it was fantastic. I learned a whole bunch, and I'm sure our listeners will learn a lot too. So thank you guys so much for giving us your time. It was wonderful.
Thanks for having us, guys.
Thank you.
The number you have dialed has been changed. The new number is...
This has been another episode of The Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you high-value, practice-changing knowledge, and to do that, we need your feedback. So subscribe, rate, and review the show on Apple Podcasts or any other podcast app. Or contact us at thecribsiders@gmail.com. A special thanks to our producer for this episode, Jess Kelly, our showrunner, Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook.
This has been Jess Kelly.
And this has been Chris the Chu Man Chu. Thank you and good night. And if you've made it to the end, you're going to be treated to another poem written by AI. In the quietude of the solemn room, a tale of caution and of gloom. Pediatric cervical spine, a fragile trust, where bones may break and dreams may rust. Dear parent, gather close and hear the journey of healing both far and near. A fall, a twist, a sudden blow can jolt the spine where nerves enterrow. Your child now stilled, embraced, with gentle hands and haste unchased. Images captured in shades of gray reveal the fractures where dangers lay. Yet now, with PECARN's rule in hand, specific for youth, it helps us stand to decide if scans are truly needed or further rays can be unheeded. Management strict, a path we tread, with collars firm to cradle the head. Surgery's art may also play to realign two men to stay. Medications to ease the pain and therapies to regain what was lost in that fateful blink, to teach or strengthen, to interlink. Fear not, through shadows round us creep, for vigilance is ours to keep. With each careful step, each measured care, we'll guard your child from further snare. In this hollowed space of whispered lights, we'll bear the burdens, uphold the rights. With science and heart intertwined so tight, we fight the darkness, we bring the light. See you guys.